And so that's going to have an effect upon the larger hospitals. And so again, what I'd like to see, Renee, is the number of the hospital census and the ICU census, the numbers of unstaffed and staffed beds from 2019 to 2020, and the number of part-time, full-time, and traveling nurses in that time space. Because if you have all the beds in the world, you don't have nurses to take care of those people. Those beds might as well not be there because you don't have anybody to take care of that person. And exactly. And I acknowledge that issue. And then also when it comes to COVID testing, or any of you could answer this maybe. Has the virus been isolated and replicated in order to make a better test? And also, has there been a gold standard for the PCR test?
So the PCR test, the current iteration that we have, is very sensitive and it's very specific. What we know is that as a testing methodology, it's cycled. Every time you have RNA, you double the amount there until you get a positive signal. And each time it doubles is a cycle time. When you run a PCR test and the cycle time is 12, 13, that means that viral load is very high. You have a strong chance that the virus that patient has is highly infectious. They're shedding it, they're contagious. So if you have a PCR test where the cycle time is 35 or higher, you're stretching the capacity of that test to detect something there. And when you're cycling, you get a positive signal when it's 35 or higher, then potentially all you're picking up are viral fragments of the RNA, fragments of nucleic acid. It's no longer intact virus, it's no longer infectious. That patient who has that PCR test result is likely no longer contagious. What we know about the natural history of infection is that people get symptomatic, they got exposed, they got infected, they become symptomatic. 10 days later, when populations have been looked at, the PCR cycle times are that high, and more importantly, these folks have specimens submitted to the laboratory to see if you can get the virus, you can culture the virus out, if you can get something alive. And those individuals, on average, 10 days after symptoms, and by then they're better, they're breathing easier, they're no longer requiring oxygen, they're no longer got a fever. There's no virus detectable in those individuals.
Okay,
they're
so
no longer contagious.
Okay, so all right, excuse me, I'm sorry. So let's try this again. Has the virus been isolated and replicated, and has there been a gold standard set for the PCR test?
The virus has been isolated. There have been genetic studies on it to say that people who get reinfected actually have a second different strain of virus. In terms of a gold standard, the PCR test is still the gold standard that we have. There's nothing better out there. There's nothing more sensitive. There's nothing more specific.
So as a percentage, how accurate would you say that the current COVID test is? Because I keep hearing about several people getting false positives, false negatives, and I know that there's going to be some in any situation, but what's the percentage rate, would you say, of the accuracy of each individual test?
So again, as you point out, how well these tests perform depends on the timing, when it is that you draw it, the technique. Properly done, you're going to have a PCR test that's better than 97% sensitive and 99% specific. In other words, it's a positive result means what you got there is likely to be coronavirus, SARS coronavirus, COVID-19, and not any other virus. Sensitivity, of course, means if the virus is there, what are its success of picking it up? That's just the test characteristic. What people don't realize is that as clinicians, as doctors, we take the flip side of the equation. We ask ourselves, if this test is positive, what are the chances that the patient really has the disease? If this test is negative, what are the chances the patient doesn't have the disease? Those are slightly different questions. And that's what we ask on a day-by-day basis when we're confronted with the result. In simplest terms, like, how believable is this result? And I can tell you right now, the PCR test result is the most believable thing we have out there.
Okay, so and again, just to reiterate for Renee, what I would like to see in future meetings is again those numbers from 2019 to 2020, the hospital census, ICU census, numbers of unstaffed and staffed beds, and number of full-time, part-time, and traveling nurses. If you could get me that information at the next meeting, I'd greatly appreciate it. Also, what are your thoughts? It shows here, I'm on the state's website right now. 829,052 tests have been done in the state. Unique individuals, 286,196 individuals. So roughly about a third, maybe a little bit more of the third of the state has been tested. So that looks like about each of these individuals have received the test 2.8 times approximately. What is the point of incentivizing people to be getting these tests? I've heard reports of certain universities giving kids food vouchers, putting them in a drawing for $500. Whenever you come into a hospital, the first thing they do is they test you for COVID. These are very concerning things for me. Other states, from what I've heard again, other states, who they test is people who have symptoms, people who are sick.
I'm so sorry,
people who,
Sharon.
even if they have small indications of a sickness, that's what they test. They don't have these great big huge test drives. They don't have incentives. They're basically more or less financially incentivizing people in North Dakota to get tested more often. What do you say to the ethics of that?